Good afternoon, everyone. On the behalf of Asia Pacific Federation of Clinical Biochemistry and Laboratory Medicine, it gives me a great pleasure to welcome you all to today's webinar. This event is part of the APFCB webcast and e-learning program, an initiative proudly introduced by the Communication and Publication Committee and supported by our knowledge partner, Quidel Ortho, to foster knowledge sharing and professional development across the region. Today's session is the second in this series centered around the theme of protecting health in Asia Pacific, laboratory advances, and lead exposure prevention. And we are delighted to have such an outstanding panel of experts with us. It is now my privilege to introduce our esteemed moderator, Dr. Praveen Sharma, who truly needs no introduction, a distinguished figure in the field of clinical biochemistry. Dr. Sharma's contribution to the laboratory medicine and education have been remarkable. We are fortunate to have him to lead the discussion today. Dr. Praveen Sharma presently is the Secretary of APFCB, Chair of IFCC CCLM, and the President of Indian Society of Lead Awareness and Research. Dr. Praveen Sharma, sir, now over to you.
Thank you, everyone, whosoever is joining from different part of this globe. So, good morning, good evening, and good afternoon. This topic is so well chosen by the APFCB because, you know, it is also one of the disease which has been overlooked for years together. And this is also one of the important non-communicable disease because metal toxicity is so prevalent in most of the countries, developing and underdeveloping countries. So this is the time that we look for the deleterious effects of metal toxicity. Since I have been working on this problem for quite long time, lead toxicity, and it is so much prevalent in this country, and I tell you, almost about 5 to 10% of rural children are suffering from lead toxicity. So today is our first and most important thing is the lead poisoning in blood, and facilities are not available in most of the places except that tertiary care hospitals. So this topic is important, and our first speaker is Dr. Vivek Pant, who is from Nepal. He is consultant biochemist and head of the research unit, Samyak Diagnostic Private Limited, Kathmandu. And he would be talking on optimizing laboratory diagnosis of lead poisoning from detection to monitoring. So monitoring is also very important. Now, Dr. Vivek served as head of department, as I already said, head of department of laboratory medicine. So I invite Vivek to deliver his talk. Dr. Vivek Pant. Dr. Vivek Pant.
Yes. Thank you, sir, for your introduction. And thank you all for joining us today in this exciting event. So before beginning our session, I would like to request all of you to take part in a survey questionnaire that we have designed today. And we'd love for all of you to join and participate in that survey. And the questionnaires must pop up over your screen right now. So I'll be discussing on the statement of problem, importance of screening, overview of lead testing methodologies and their relevance, and finally the approaches for optimizing laboratory detection. So coming to the statement of problem, WHO in 2021 listed lead as a responsible cause for 30% of the global burden of intellectual disability. And in 2021, Lancet published that for almost half of the people living in lower middle income countries, 34 lower middle income countries had elevated blood lead level more than 5 micrograms per deciliter. And UNICEF 2020 report estimated that 1 in 3 children globally have lead level more than 5, and 46% of these children are in South Asia. So this is a very critical topic for us, and screening plays the major role to identify earlier, and we will have opportunity for early intervention. As we can see in this chart, children can have neurocognitive and behavioral problem whenever their blood lead level is as low as 10 micrograms per deciliter. And these symptoms sometimes do not they are not overt, so they are indistinguishable from other similar clinical conditions. And clinicians tend to finally request for lead only in the last course of the disease. Therefore, one way to early identify the lead content in the body is through the screening method, because we will have time to intervene early. And the perfect example of screening can be seen in case of Georgia. Back in 2018, they were able to identify the adulterated spices as a common cause of increased lead level in population in the west part of the country. And therefore, policymakers were able to handle this and curb the contaminated spices. Now, coming to reference interval for lead in the blood. So actually, lead is known to cause neurocognitive problems in children, as I already mentioned, and there is no safe lead level in the blood. And in 2012, the interpretation for elevated blood lead level was referred as reference value, blood lead reference value, and before that it was termed as level of concern or toxicity. So this blood lead reference value is the statistical term, and which is used to categorize individual as either elevated or not elevated, and which is again based on the population distribution of the lead level. So in a population where everyone has high blood level, one can use the terminology blood lead reference value. So it was set at 5 micrograms per deciliter in 2012, and again reduced to 3.5 in 2021. And in countries where blood lead distribution is not known, like in our case, WHO recommends using 5 microgram per deciliter as a threshold. So in human body, the lead content in human body can be estimated through using various human tissues and body fluids. However, since the lead is 99% bound to the red blood cell, so blood quantification of lead in whole blood is the mostly used screening tool and diagnostic testing tool, because we have well-established method for sample collection, blood sample collection, and there are literature supporting the linkage of blood lead concentration with the clinical effects and treatment outcome. And we also have validated analytical methods and reliable QC materials and certified reference materials for blood lead estimation. So coming to the analytical methods that are being used worldwide to estimate lead content in the blood. Before 1960, the colorimetry and spectrophotometry methods were in use. However, it was in 1968, I guess. Yes, in 1968, first time flame atomic absorption photometry was used in the United States to estimate the lead content in occupationally exposed individual. And in 1971, for the first time, anodic stripping voltammetry, the benchtop instruments were proposed. And those days, the graphite electrode was used, but nowadays, as you can see, it is marketed at Lead Care instrument. They have fixed screen-printed electrodes. And in the 1980s, the decade of 1980s was devoted to the fully understanding the features of graphite furnace atomic absorption spectrometry, and thereafter it is being used widely in many parts of the world. And inductively coupled plasma mass spectrometry emerged in early 2000, and in 2005 it was used for National Health and Nutrition Examination Survey in the United States, and it's continuously emerging. So the method, ideally we have three methods. Two are laboratory developed methods and one is point of care testing method. So they differ in their analytical capabilities, the cost and technical requirements. So decision about the choice of method depends on the setting and resources of the laboratory, and of course the population you are going to serve, the laboratory is going to serve. So we'll see each of these methods individually. First of all, this is the brief overview of comparison of these three methods. As I already mentioned, the late care instrument is CLIA-waived point of care test, and it has all the features of point of care test. It's cheaper than the laboratory developed test and is portable, and samples can be taken and analyzed at the field also. And these two laboratory developed methods are quite expensive and requires expertise or technical expertise to run and to operate them. And the turnaround time is more or less similar in each of these methods. So first of all, graphite furnace atomic absorption spectrometry was first proposed before 1970. And in modern days graphite furnace atomic absorption spectrometry, they use a graphite tube which can resist the excessive heat through inflowing of the argon gas. And there are various drying stages. First of all, first drying stage evaporates the solvent, and next stage pyrolysis again evaporates the blood matrix, and finally there is atomization step at very high temperature where the leads are volatilized, the lead ions are volatilized, and through the use of hollow cathode lamp, the absorbance is measured at 283 nanometer, and the report are available then. So what are the ways to optimize the graphite furnace atomic absorption spectrometry? First of all, coming to calibration. The calibration range should be adjusted to fit the current population blood lead level. So it depends on the country where this is being optimized. And the lead standard solution should also be traceable to the SI unit by a certificate issued by NIST. And previously, aqueous lead standards were used. However, these days, the blood-based or matrix-matched calibrations are used, calibrator are used, and it's mandatory. So actually, there is no universal furnace program for blood lead due to design variation among the manufacturers. And there are often technical notes by the manufacturers, which are helpful to set up and optimize the furnace contents. So the minimal criteria are regarding the injection volume, the atomization efficiency, and which is related to the sensitivity, will decrease when the volume of the diluted blood deposited increases, and this will eventually require optimization in other subsequent steps. So once the blood sample gets deposited in the platform, the carbon will build up, so extra oxygen assaying step may be required, and frequent deep cleaning with ethanol or alcohol is also advised, and drying can be done in various stages. And in pyrolysis, which is done in using more than 600 degrees Celsius temperature, it volatilizes the lead. So there are various modifiers used to stabilize the lead. For example, in modern day instrument, phosphotungsten modifier is used, and there are also different modifiers available like phosphate modifier. However, one has to optimize the modifier by varying the temperature and recording the absorbance. And after pyrolysis, atomization studies are done, and atomization profile is studied for symmetry. And finally, the instrument performance is monitored using the characteristic mass daily, which is a absorbance number from a fixed molar amount of atoms. And it should be ideally within plus minus 20% of the expected value. And finally, any discrepancies should be troubleshooted. So after optimization, what should be done? And it's a regular part of our laboratory. We have to conduct validation studies, and there are numerous certified quality control materials that are analyzed for estimation of accuracy and precision. And the mean and expanded uncertainty is calculated depending on the population you are going to serve, and one has to participate in the proficiency testing programs. So earlier, CLIA recommended plus minus 4 microgram per deciliter. However, there has been calls over the recent year to tighten these proficiency limits to plus minus 2 micrograms per deciliter. So there are various studies available where they have optimized the graphite furnace method. So this is one study where they had to serve the patient in emergency department who came with acute abdominal pain, and since blood lead should be higher than 65 or 70 to cause acute abdominal pain, so the standard calibrator used in this study was ranging from 10 to 100 micrograms. So one can optimize according to the population they are going to serve. And despite having limited analytical working range and requirement of laboratory expertise, and the graphite furnace atomic absorption spectrometry have strength in terms of lower limit of detections, can analyze small sample volume, and can be fitted with the auto samplers. Now coming to inductively coupled mass spectrometry, and it's continuously evolving. These are various mass spectrometry methods are available according to the manufacturer, and they implement the optimization procedure, which are somewhat different according to the manufacturer. So there are application support team and technical notes provided by the manufacturer that are helpful to optimize the ICP-MS method, and also helps to set up the early instrumentation. So this diagram depicts the principle used in the ICP-MS. So after the sample gets inside the nebulizer, the ICP, inductively coupled plasma, hits it and converts it into the ions, and these ions through the interface gets inside to the mass spectrometer from atmospheric pressure to the vacuum, and this will create the concentration of ions based on their mass to charge ratio. However, this basic principle may also vary depending on the type of spectrometer one is using. So coming to optimization of ICP-MS, and this is quite different from different manufacturers. So one has to rely on the technical notes provided by the manufacturer. However, after following these basic steps, one can optimize the ICP-MS in their laboratory. First of all, maintenance of blood adequate homogeneity is very important, because since lead is bound to the RBC, 99% of lead is bound to the RBC, so adequate vortexing and pipetting is essential to avoid clots in the sample, and very strict contamination control should be there in the laboratory with the use of purest form of water, and likewise in sample preparation, which is the most important part and also time-consuming part in ICP-MS. One can perform it through either dilution or digestion technique. While dilution technique was used earlier and it's easier, but one has to match the matrix using matrix matched calibrators. So again, the internal standards can be used to minimize the matrix effects, and if one is using internal standard, then both the blank subtraction for internal standards and reagents can be done for better accuracy and precision. So appropriate spacing of the calibrators can be done, and there are three important timings where one can optimize the ICP-MS instrument: delay, analysis, and range time. And finally, when results are out, one has to follow the strict and rigorous quality control measures, and method validation should be fully according to the CLSI protocol. So despite having high cost and requirement of very skilled laboratory staff, the major strength of ICP-MS are very low limit of detection and can analyze a small sample volume and very fast turnaround time, and it has also multi-element analysis capabilities. So this is the recent study from India, where they developed and validated ICP-MS method to assess the blood lead content in occupationally exposed lead smelting plant workers with the use of calibrators that span from minimal LOD to maximum concentration of 100 micrograms per deciliter. Coming to the final method, anodic stripping voltammetry. I think most of us are using this method in our laboratory, and this is based on the electrochemistry, where 50 microliters of whole blood is mixed with the manufacturer provided reagent, which is usually hydrochloric acid, and after it is mixed, that mixture is kept in the sensor tubes that are inserted inside the machine, and a negative potential is applied to the sensor to accumulate the lead on the electrode, and the potential is rapidly reversed, and this reversed or stripped, therefore the name anionic stripping voltammetry, and this stripping current is proportional to the lead content in the whole blood. So it has a fixed reportable range ranging from 3.3 to 65 micrograms per deciliter, and easy to calibrate because the user calibrates the analyzer for each new lot of sensor by just touching the electronic calibration button provided by the manufacturer. However, there were 2 recalls in 2017 because of the reporting of low blood test results for venous blood sample, because one has to use capillary blood sample in ASV devices. However, in the recent years, a compound theorem was detected, which is present in the rubber tubers of the blood collection tube, and it releases compound named carbon disulfide and carbonyl sulfide, which can dissolve into the blood sample and tightly bind to lead, leading to false low value. So there are various studies comparing the LEAD-Care2 instrument, which is a marketed ASV device, with graphite furnace atomic absorption spectrometry, and it was concluded that significant bias are seen at lower values. Despite this bias, the easy accessibility of these devices and their ability to detect the blood lead level more than 5 micrograms per deciliter will remain unchanged. Therefore, these devices are very useful tool for screening individuals in our setting who otherwise might not be identified at all. And blood lead concentration higher than operating range have been successfully measured using the appropriate sample dilution techniques, even in the LEAD-Care2 instrument, because it has fixed reportable range of 3.3 to 65. And using this study, we had an opportunity to report a case of acute abdomen secondary to lead poisoning, where the baseline blood lead value was 82.3 micrograms per deciliter. So ASV has all the features of point of care device, and the major limitation is high risk of sample contamination. So 2 key questions that should be considered when optimizing blood lead analysis are: first is sensitivity. For each of these 3 methods, is 3.5 microgram per deciliter or any other population data is available, is it above the limit of detection? And next is precision. Is the measurement precision at 3.5 microgram per deciliter or local data adequate for clinical use? And yes, we have studies where the reportable published lower limit of detection is, lower limit is 0.05 for ICP-MS, 0.08 for graphite furnace, and fixed 3.3 for LEAD-Care2. And this CDC's lead and multi-element program, LAMP study, estimated the precision based on the pools from the proficiency testing sample, and each of these methods had less than 3.5. So my conclusion is that for optimizing laboratory blood detection techniques, the material contamination controls should be very strict, and there should be strict calibration protocols. Use of blood matrix matched calibrators are compulsory now. And quality control is spanning all the labels should be used, and there should be guidelines for repeat analysis. And from a clinical perspective, more emphasis should be placed on improving the measurement reliability in interval of 1 to 10 micrograms per deciliter, where most population blood lead level nowadays fall. So this was a study from 1980, where the lead content in the air in Himalayas of Nepal was very negligible. And in the same year, the concentration of lead in blood was found to be 3.4 micrograms per deciliter. However, due to urbanization and advancement of the human civilization, the cases of lead toxicity are being increased. So it's time to decrease the lead level, average lead level. So it can be done through our combined effort to take back the value to this prehistorical value. Thank you. Thank you.
Thank you, Dr. Vivek. Excellent talk. But there are few issues are always there. You know, with the advancement of the technology, we are getting better instruments for the estimation of lead. Okay. ICP-MS is considered to be one of the finest instruments for the estimation of lead and other metal. The question is, what is the cost of estimation of lead in ICP-MS? What would be the cost?
Yes, thank you. Thank you, sir. So when we compare the three instruments, the running cost, of course, for mass spectrometry is very high. But when we are running many samples per day, it is almost similar to the NIRDIC stripping voltammetry. For that purpose, you have to run at least 500 samples per day. So I have shown this in my slide. When I compare the three instruments, the instrumentation cost for ICP, the instrumentation cost for ICP-MS is very high. It's around the range of 150.
Yes, ICP-MS means screening is most important. Screening of population. What instrument will you suggest for screening purpose? It is Leadcare-2.
Yes, for screening purpose, Leadcare-2 has been recommended by the international guidelines. Actually, in 2009, the graphite furnace atomic absorption spectrometry, ICP-MS, and Leadcare-2, along with the isotope dilution mass spectrometry were compared, and results were quite similar. So graphite furnace and Leadcare-2 are used for screening and diagnostic purpose, whereas for biomonitoring and determining the baseline population lead distribution, ICP-MS method is used. For our setting, Leadcare-2 is perfect.
Because both this graphite furnace, AAS, and ICP-MS, you need more sample. Okay, then the cost would be reasonable and affordable. And you can't estimate single or AAS. Another problem is with the standardization, because calibrators are normally not available, and calibrators of metal, they are very, isn't that?
Yes, sir.
Because to best of my knowledge, it is only Bio-Rad gives you calibrator for lead toxicity. For the estimation of lead. Do you any other calibrator for this purpose?
No, sir. I have no idea about other calibrators besides Bio-Rad.
Oh. Thank you, Vivek, for the excellent presentation. We'll switch on to our next talk. This will be delivered by Dr. Hafja Mazid from Pakistan. She is Director, Chemical Pathology and in charge of residency program, Pathology and Laboratory Medicine, Aga Khan University, Karachi, Pakistan. She would be talking on lead poisoning in vulnerable population, assessing risk and implementing and prevention strategies. So I invite Hafja Mazid for.
Thank you, Dr. Praveen, and thank you, organizers, for the invite. So, hello, everyone. Good afternoon, good morning. So, today I'm talking about the vulnerable populations and the preventive strategies which can be implemented in this group of population. So, this is my outline of the presentation. So, I have no conflict of interest to declare. So, lead poisoning, as we all know, is a major public health problem. It does not occur in just a few months. So, it takes years and years to build and accumulate the lead builds up in the body. And the WHO has now labeled as that no blood level of lead is safe. So, even a smaller amount of lead present in your body can cause serious health issues. as it is considered among the most toxic elements in the periodic table. It's a neurotoxic element, hence the intellectual disability caused from this is very high, and the most vulnerable population for that is obviously children who are at the development phase and obviously consume more, absorb more nutrients, more water, more food as compared to the adults. So hence they are more vulnerable to developing the lead poisoning as well. So according to the former director of US Environmental Protection Agency, the most biggest achievement of all time is that elimination of the gasoline lead. So this began in 1986, and the last country to eliminate lead from its fuels was Algeria. Even after the elimination of the leaded gasoline, we still, in the last 3 years, we are still seeing that the blood lead levels of the populations, they're still higher than the action levels as recommended by the WHO, which is 5 microgram per DL. And a significant chunk of the population is affected by this. So this diagram shows here the age standardized, the summary of exposure value for lead for both the sexes. And you can see that the most affected areas. So one thing I would like to add here is lead is described as a level 3 risk. So in public health, an environmental risk assessment, so levels are given, risk level 1, 2, 3 are given to classify hazards based on their severity, based on their prevalence and impact on the human health. So lead is considered, so if a hazard has limited exposure or limited risk to the public health, it does not require, it can be easily managed, and it does not require immediate intervention. That is considered level 1 risk. While if the risk is the public health risk is higher, and the disorder requires urgent attention and significant intervention is required for its prevention and mitigation, then that hazard is considered as level 3 risk. So lead is considered as a level 3 risk by the agencies. And as you can see, that problem is more significant in Asia Pacific region. So this diagram shows here the pooled blood lead levels in children in 34 low income and low middle income countries. And as you can see, in most of the countries, so the gray areas are where the data was not available. So as you can see, most of the countries, they are in the African or Asian region. So and most prevalent, like highest blood lead levels were found in 2 of the South Asian countries. So this, which makes this problem more relevant for our Asia Pacific region. And it shows that we need the significance of this problem for our region, and it shows that we need to come up with measures to prevent it. So moving on to the sources of lead can come from various sources. So sources can also vary terrain-wise, geographically, depending on your industrial activity, your local policies, and how well those policies are implemented. So WHO has told us that there are 2 ways that you can get the lead exposure from. So it's mainly, it can be environmental sources or occupational, and so usually the ingestion form is from the dust, soil, water, and it can be through the ingestion through the agricultural products, vegetable, when the pesticides or some contaminated foods is consumed, and inhalation of the lead particles when you're working in some lead-related industry. So, and the lead industry advocates, they tell us that the lead is the most recycled metal, And and we know that most of this recycling occurs within the countries that are incapable of enforcing the environmental regulations, which is the low middle income and low income countries. Again, which makes this more relevant for our own region, as millions of metric tons of lead is dispersed into the environment each year, and more in the our part of the world, which again shows that this problem is significant for our population. Hence, we are the ones who need to take actions for it. So lead has been particularly used in different products for many years. And this figure shows here a list of different products which can lead to lead exposure. And you must appreciate that nearly more than half of these sources, they belong to household and building material related. So like they can directly affect directly affect the persons, patients, the elderly, the children, the pregnant women. And also to note, also point to note is that when we talk about preventive strategies, is that the lead exposure, the lead sources, they may differ geographically. So the low middle income countries and the high middle income countries, they may have different sources. So you need to identify sources of lead exposure in each region so that you can work on the relevant strategies. So like you can see here in China and India, paint and traditional medicines are considered as an important source of lead exposure. While in Nigeria, you can see the environmental, water, soil, air, they are more relevant lead exposure sources. While in Mexico, the cookware, the lead containing cookware are more important for the lead source. So there's a need to determine these sources of lead in the Asia Pacific region through maybe we can do a survey or a collaborative study to identify what are the sources in the Asia Pacific region. Only then, because once we know these sources, only then you can work on eliminating it by implementing relevant strategies. So moving on to the health impact of lead. So this lead has been found to induce oxidative stress by production of free radicals, which then causes the membrane damage via the lipid peroxidation. And as you can appreciate here that many systems, not just one system, many systems are affected by the lead. And if we talk about the overall impact of the lead, so one very frequently heard argument from the lead industry advocates is that it brings in money. So how much money is it bringing in? Is it bringing in more money than it is causing harm to the health? So one estimate is that the total profits of the lead industry is almost 0.1 trillion. But as opposed to it, when you see the health harms related to the lead exposure, it is more than 6 trillions. So the cumulative harm to health is way more than the profits brought in by the lead industry. And particularly affected population is children, because they absorb 4 to 5 times as much lead as an adult from the same, if the same dose is ingested by the two. Which brings us to our next part of the presentation, which is the vulnerable population. So which are those vulnerable population? These are the vulnerable population, the children which are developing, so they are highly susceptible, the pregnant women, the low income communities, because the impoverished communities, they have different environmental socioeconomic factors. They do not have monitoring systems, they do not have policies, even if the policies are present, they are not implemented. And also Poverty leads to malnourishment, and malnourished people, malnourished children especially, are more prone to developing lead poisoning, because when their diet is nutrient deficient, especially when there's deficiency of calcium and iron, they're more prone to absorb more lead, leading to the poisoning. So in the interest of time, I'll be focusing on just two vulnerable population, that is children and pregnant women. So moving on to children. So young children are particularly vulnerable to lead poisoning, as already mentioned, because they absorb more lead. And also because the children are curious. They have to touch everything, they have to taste everything, and their frequent hand to mouth and object to mouth behaviors, they increase their risk of exposure to lead contaminated objects, from paint, soil, from pica eating, from dust. So, and also this pica eating, the non-food containing the non-food items eating behavior is also common in children. And according to a survey, the children breathe, drink, and eat more per unit of body weight than adults, hence more susceptible to lead exposure. Blood-brain barrier is still developing in children, especially at younger ages, hence more neurotoxicity and intellectual disabilities. So the children who are less than 5 years of age, they are more prone to develop the neurological, cognitive, and physical damage compared to their peers who are not exposed. While older children who are exposed to lead, they are prone to develop increased cardiovascular deaths and kidney damages. According to WHO, so there is no safe level of lead. So any level of lead is a potent neurotoxin, as already discussed by the previous presenter too. And even low lead exposure can lead to your intellectual quotient decrease. According to a survey, even 1 microgram per DL blood lead level is associated with a loss of 1 IQ point. And you can very well, understand if the children have more than 5 microgram per DL blood lead levels, they may have more decline in the IQ points, which will then not just affect the potential of that child, but when the prevalence of lead toxicity is high in a society, it decreases the overall economic productivity of the society, of the entire society. And as you can see here in this study, that the most common cause of non-toxic blood lead levels less than 5, it was pica eating in children, and for toxic level, it was living in congested areas. So, and this shows the comparison of the lead exposed while the lead non-exposed children. And you can see that lead exposed children have low IQ, low mean IQ compared to their peers. So moving on to our next vulnerable population, which is pregnant women. So once lead enters the body, it is distributed to all the organs, including your brain, your kidney, your liver, your bones. So lead stored in bone and teeth, it keeps on accumulating over time. And when a woman gets pregnant, the lead, it may get dissolved, and it is moved from the bone it can get moved from the bone into the blood and expose the fetus to the lead poisoning. And during pregnancy, it can harm the developing baby, and it can also cause the long-term neurological deficit in the fetus. In pregnant female, lead can cause increased risk of miscarriage, premature birth, low birth weights, and in the fetus, learning behavior problems in the learning behavior, and even developmental problems later on in the life. So when we talk about the preventive strategies, the UNICEF and Pure Health, the toxic group, they came up with the 6-pronged strategies. So their strategies was to develop a monitoring system, build the capacity of the labs, of the field persons for testing the blood lead levels, monitoring, doing the household surveys, or if the household surveys are already done in your country, include the blood lead level testing in those surveys, determine do surveys to determine the sources of exposure, identify lead contaminated areas, take preventive and control measures, identify sites, clean them, identify the most lead exposure of your area, sources of lead exposure in your area, try and eliminate them. For the management, treatment, and remediation, improve the strengthen the primary healthcare systems of the system, so that they can provide not just the management of the lead poisoning, but the preventive measures through improved nutrition of the children and the pregnant females, doing public awareness campaigns, behavioral change campaigns, improving the legislation, policies, and making the relevant SOPs for your region for implementation of those SOPs. So there's a need to take global and regional action. And as you can see from the previous slides, that not one person can take this action. So what is the way forward? So we need to bring together all the persons, not just the lab experts and the clinical toxicology experts, but the representatives from the international organizations such as WHO, UNICEF, UNEP, the regulatory bodies, your government policymakers, your public health professionals, your academic and research institutes who can work on understanding the lead poisoning and the research on the ways and strategies which we can implement for the elimination of the lead from all the products. You need to bring the industry experts on the table too, because they are one of the key players in this area. And without bringing them, you cannot, single-handedly or, alone, eliminate the lead from the society. So there's a need to develop a consortium of all these multidisciplinary groups and of people, and we can then work on the lead exposure prevention and advanced detection. So we have no time to lose. So we need to come up with strategies for prevention of lead. There is a need to develop lead registry for exposed patients, or do the surveys for the vulnerable population to determine the exact prevalence of lead exposure, as well as the blood lead levels in your population or the sources of lead in your population. We need to educate masses through the CMEs, workshops, courses, increase awareness about the lead exposure and how it can lead to detrimental health, how detrimental impact on your health. And we need to, come up with some specific, if not complete fellowships, but we can introduce modules into the toxicology fellowships for the lead exposure prevention and advanced detection. So to conclude, lead exposure can harm multiple body systems, posing significant risk to young children and women of childbearing age. Once in the body, lead is distributed to all your systems, where it accumulates over time, particularly in teeth and bones. During pregnancy, it can expose the fetus to high blood lead levels, and human exposure is commonly assessed by blood lead levels, and no lead exposure is considered safe, yet its harmful effects are entirely preventable through effective interventions and policies. So there's a need to work together to eliminate this risk. Thank you.
Thank you, Dr. Majid, for an excellent talk and giving comprehensive account of lead toxicity and how it affects the most of the body part. Various methods are available, policies are being framed by the government all across the world, but somehow the city still remains one of the important or one of the great problems for the children. So, to best of my knowledge, awareness program for teaching population of the deleterious effect of lead poisoning is most important. Monitoring is not possible in most of the countries. So what to do? Because costing is very high, estimation of estimation if we teachers of toxicity or make children aware of this, and prevent mental toxicity. Because lot of one of the role of lead grommet in adulteration of spices, how it can be detected. Do you have ever thought about this detection method of lead grommet in food products?
So your voice is breaking. So what I was able to understand was that you're talking about that education or mass awareness for lead prevention is important as compared to policy implementation or policy development. So I'll respond to that.
Then one of the participants is asking for how to detect lead grommet in the food, because lead grommet is used as adulterant in spices.
Okay. So I'm not sure about the second part of the question, how it can be detected, Mr. Anuradha. But yes, lead content in the spices can be measured, and as a case study shown by Vivek, that it was a kind of a success story in Georgia where they were able to eliminate this risk from their food products, from their spices, and it led to very good outcomes in the children.
Similarly, most of these indigenous drugs or Ayurvedic drugs, they are, always added with lead for some reason. Lead toxicity may also be because of this Ayurvedic and indigenous traditional medicines. They are also very, very, responsible for lead toxicity. And besides this, paint industry, battery industry, so they are also, made aware of lead toxicity, because I have visited one of the leading battery industry in Amara Raja batteries, which is known as AMCO batteries. So I found that they have taken 100% prevention measures in their industry. And even the blood lead level in their workers was so as high as 40 or 50 microgram per liter, which is now reduced to less than 5 microgram per liter. And it was only, it could have been, it has been possible only because of, lead awareness program. And in India, we have conducted several lead awareness programs in different schools, and we have been teaching teachers about this. So awareness programs should be a priority area, and through which we can definitely prevent this toxicity.
Yes, sir. I 100% agree with you. And your last point was really relevant. I'm also a teacher of undergraduate medical students as well
Oh,
as the
great,
postgraduate
great.
students. So not just the awareness and teaching at the education at the postgraduate and undergraduate level, but what you
Yeah,
talk about
yeah.
schools, that is very important.
Yes,
You have to
yes.
teach and raise awareness at every tier of education, starting from the early childhood to college to universities and postgraduate. So that is very, I 100% agree with you. Teaching at every tier is important.
And we must teach them how to clean, because it is hand to mouth problem is there, because children always will touch something and then they will take it to their mouth. So washing of hands, and then not to chew that pencil. So likewise, we must teach them not many things, and I think that is quite possible. Instead of is very difficult. Is very difficult, and then estimation again. When you estimate blood lead level, that is very expensive. And once you are suffering with lead toxicity, treatment is very hard. And metal toxicity. Thank you.
Thank you, sir.
Thank you, Deepak.
Thanks a lot, sir. Thank you so much. What I can say that when we have a leading expert, how are you, sir? I'm really thankful to all of you. And my special thanks to Professor Praveen Sharma for accepting to be a moderator for this important topic about the lead toxicity. And while I see that, it is a very important topic, especially that all of you have mentioned in developing countries. So even a small amount, we cannot define the safe amount of lead exposure. So even a smallest amount of exposure can lead to a long-term health hazard. And all of you have, exchanged the ideas and beautifully explained this problem in such a fantastic way, and such an important topic that we should be really take to the academics, to research, and for the prevention purposes, of course, for sure. So, sir, thank you so much, Professor Praveen Sharma, taking out time in spite of his busy schedule, though we could see that he's always quite busy with many different things, and he's also leading a charge of the Secretary APFCB, along with the leading as a chair of the ICCC Salem Committee, and was also the president of Indian Society of the Lead Awareness and Research. And I'm also thankful to Dr. Vivek, a part of committee, and our leading speaker about the detection and monitoring of lead exposure from Nepal. And our next eminent speaker, Dr. Hafsa Mazid from Pakistan, Director of Chemical Pathology Residence Program, Aga Khan University, Karachi, Pakistan. And of course, this program cannot be completed, this fantastic program and initiative by the Communication Publication Committee, and it cannot be complete without giving thanks and mentioning the name of our team who is working all around behind the scene, Dr. Deepak Parchwani, coordinator of the APFCB webcast program. And my special mention and thanks to our Quiddle Ortho team and Dr. Mayank Upadhyay, who's also the coordinator of our webcast e-learning program, and also as a part of the coordinator from the Quiddle Ortho as a knowledge partner. And also special mention to Shannon, an official from the Quiddle Ortho, and a part of a marketing team and heading at the Singapore with the Singapore team. And of course, our participants for those APFCB community, for those whom we have, arranged and we have managed to gather such a fantastic program. Thanks to all the participants for taking our time and meeting with APFCB community. And I also request to the participants to please, deal with the survey questions that is available during this particular program. Also, if anybody left during the same time, we're going to email to you, and we request that you please complete those survey questionnaires. So it will be helpful to start with some more need-based programs and to understand the requirements from the participants' point of view. So I'm very, very thankful to all of you, and thank you very much for your better time and helping us to lead with APFCB webcast program. Thank you so much to all of you. Thank you.
Thank you, Pradeep. Thank you.
Thank you, sir.
Thanks.
Thank you.